Delighted to introduce Professor Rabi Chow from Germany, who's going to talk to us about genetic investigations for fetuses with cardiac problems. This is a huge area, and increasingly we are referring patients. We're very fortunate in National Maternity Hospital to have a perinatal geneticist, and increasingly we are finding genetic causes for our cardiac defects. Rabi Chow, between 2001 and 2004, was Professor of Obstetrics and Gynecology in the Charité University Hospital in Berlin, and since 2004 has worked in the Center of Prenatal Diagnosis and Human Genetics, also in Berlin. He's an ISUOG member since 1994, and he's been a board member from 2003 to 2013, including 2 terms as chair of the Education Committee, and has received the Stuart Campbell Award for Education in 2018. Thank you, Rabi.
Thank you. Let me check. I think I was 92. At the second meeting I was, or because it was in Germany, and I have one of the early numbers, 140 or something like that. So thank you, Fanula. Thank you, Simon. Where is Simon? Behind? Okay, preparing the... And thank you very much for the kind invitation to come to Dublin. So I was expecting to come to Dublin 2020, but due to COVID, so we could not do it. So we gave over the in Berlin that we are coming next year to Dublin. So I was asked to speak on genetic investigation, fetal cardiac defects, a practical guide. Well, if we want to have a practical guide, this could be the easiest way to be doing it. We identify first cardiac anomaly, we perform amniocentesis, and we call the geneticist, please do everything, karyotype, array, and exome. And if you ask, would you like something more? I said, 1 espresso, please. So this could be the easiest way, and I could stop here, because at the end of the day, this is more or less the message. But you are still excited to listen what we can do, and this is not the way we want to do. So, but listen, knowledge is increasing, and if you look at the recent issue of the fetal heart book, we added some, I don't know, more 100 pages, and only for geneticists we had 50% more, because in the past there was no exome. Today we have a lot of include with exome. And when Dario showed his book, I'll show you also mine. You see here's the Andy Warhol inspiration on 3D. So let's start now discussing basic things. First of all, we'll always think about numerical aberrations, but to my experience, it's getting less and less important, because many people will see they will have already an IPT, or they will start doing an IPT. So with an IPT, we have been solving, almost 75% of the cases. And the classical cardiac anomalies for trisomy 21 are the septal defects, plus the ARSA and some other tiny details like an echogenic focus occasionally in the small thymus, so the linear insertion of the valves, and so on. For trisomy 18, we should think over when we have conotruncal anomalies. In general, we have many other abnormalities in the fetus, so don't underestimate the role of your ultrasound, despite having, let's say, a so-called normal NIPT. We had several cases where it was missed, especially when you have twin gestations, for example. You have the typical additional signs. And the same can be done with trisomy 13 and with trisomy, with Turner syndrome. But you see such a condition here, mesocardia 14 weeks with the VST, an ARSA, and single umbilical artery, facial dysmorphism, dilated fossa. She had a normal NIPT, and you do CVS, and you find out the trisomy 9. So this is why for us, we start always, and ideally by having CVS. This is why, from my feeling, the best scenario is really to have a diagnosis done in first semester, because you have next day the karyotype, a day later 22q11, and then you can think over going to exome directly. So this is how we approach. So this is why, more or less, keep in mind 10 to 15% of heart anomalies are due to any aneuploidies. Now, we can discuss in depth the role of copy number variants, but you'll see it's a little bit relative today, because we know the experience. The most important anomaly is 22q11, especially when we are discussing on the heart. For 5 reasons important. It is most common deletion in humans. It is after trisomy 21, the second explanation of a cardiac anomaly, because it's more than 1 to 2,000 births. Of course, we see more cases of trisomy 18, 13, because we see them early gestation, but this, from the point of view of common, it's more common, especially in second and third trimester. it is, you see, it's even neonatal emergency and also later on in life may have an impact. So what are the typical cardiac anomalies? There's the conotruncal anomalies. It means the three-vessel trachea view is already a key for two reasons. First of all, the cardiac abnormalities like the interruption of the arc and the other anomalies. But in addition, you have here the view to see the thymus. But also don't underestimate the role of some other conditions. And when you have a cardiac anomaly and you see in addition there is a right aortic arc or an ARSA, the risk goes to 90% of the cases to have a 2211 deletion. So we worked for years on the thymus, and ideally you should work on getting the highest resolution. I'm sure later on Samuel will show us how if you improve a little bit your 2D image, you can demonstrate the thymus, or you can add color, as Dario showed in his talk, to demonstrate the thigh boxes are the two boundaries of the thymus in the three-vessel trachea view. And you see, in such a case here, you have two right aortic arcs, one with a thymus here, the other one with a small or almost absent. And this is a normal three-vessel view, but the vessels are touching the sternum, so there is no thymus here, and this is typical 2211. Or let's say this case here, you are scanning, second opinion, 26 weeks, coarctation, yes or no? No, it is interrupted arc, especially when you see that there is no space between this and that region. What are additional signs? We reported by an accidental observation that there are some CNS abnormalities in 2211 persons, but they are not so very obvious at 22 and 23 weeks. You will see them later on, some polymicrogyria, but this is quite rare in comparison to what is reported after birth. But the dilated CSP, if you get even after 22 weeks, it will be present 90% of the cases. And this is quite, let's say, an add-on. People ask me at the end, but if I find an isolated case of CSP, okay, but you see, if you have a reference range, you have 5% of the normal population, they have a dilated CSP without any explanation. But the dilated CSP is typically found in trisomy 18 and in 2211. So if you have a combination of cardiac anomaly plus, then this is what you do. So if I enter the room, my colleague tells me, I have here right aortic arc, and ask him, show me please the thymus and show me the CSP. You have two points, and then you have already 90% of the cases detected. Well, if you look at data on 2211 syndromes postnatally, there will be also the role of the face. But we have antenatally also the role of polyhydramnios a little bit later on gestation, but we have also kidney diseases, quite rare, but it's more commonly seen today. You will have absent kidney, you have multicystic, unilateral multicystic kidney. You may have some cleft, but not as a typical facial cleft, but more cleft palate region and some CNS anomalies. So the face, well, if you do a lot of ultrasound, you will have the impression that 2211 fetuses, they have some, let's say, bulbous nose, they have a long nose, they may have absent nasal bone. So the face is mild dysmorphic, but what I don't like in the issue of the face, neither on 2D nor on 3D, is that it has always something subjective. Because if you don't have anything else, you will not say, oh, I will stop here because of this face, I will perform an invasive procedure. The same for other features. But it's always, and for this anomaly, a combination of different findings. So let me show you among many papers on the role of CNV's copy number variant. This one, because this is, for me, the one I'm using in my counseling from China paper, 600 cardiac anomalies analyzed. They found out that 20% had an abnormal findings, including the microarray, dividing it into 14 abnormal karyotype and 6% abnormal array. And this is the data you can use in your daily counseling. If you see a cardiac abnormality, tell them 15% will be due to abnormal karyotype. Wait a moment, there is the end of the slide. And then you have 6, 7%, 8% duplication, deletion. And then if you look at these, you can split into two. 50% of them are 2211, and the 50% are the others. In other words, under the bottom line, if you remove the 2211, you may have 3 to 5% being due to copy number variants, which is important, but not as high as what we'll see later on with the exome. So in other words, keep in mind, when you are doing this, you have 50% deletion and 50% the other one. And occasionally, when I find a specific cardiac abnormality, for example, aortic coarctation, I will ask for Williams-Boyden syndrome. If you have a late, let's say, second trimester with a growth retardation, with a coarctation, it's typical combination for 2211 for Williams syndrome. They are often growth retarded, or if you have a severe growth retardation with some facial anomalies, Wolff-Hirschhorn syndrome, and so on. So you may have some additional hints, but I gave up today in seeking for many details because it's really easy to have a good espresso and let the geneticist work. But sometimes you have a feeling, before running into the big shots, tell them, I have a growth retardation. Do please, in addition to 22.1, this and this fish sonde. And this is a small collection of some conditions like duplication deletion. You see here, this was an isolated left superior vena cava with growth retardation leading to a Williams syndrome. Now, what is the role of monogenic disease? And this is more important. In the past, I used to give a similar talk, but let's say the diseases here like Holt-Oram, Alagil, and they were in the upper range. Today, it's quite rare to find them because we have now not new disease, but diseases more easily diagnosed due to exome, the wide use of exome sequencing or panel. So this is one of the most common cited abnormalities, Noonan syndrome. Jacqueline Noonan was a pediatric cardiologist. She observed the combination of cardiac anomalies with some lymphatic diseases. She called at that time it is Turner syndrome-like, but without being Turner syndrome. But let's say for me and for us, it's not a typical cardiac finding, but cardiac can be apparent. It's more let's say, lymphatic disease. If you see nuchal edema, hydrothorax, thickened nucleus, persistence of nuchal insufficiency, or lymphatic sacs, or you'll think over. But among the cardiac anomalies, let's say the cardiovascular, the first one I will look at is the ductus venosus. In 30% of the cases, you have an abnormal connection of the ductus. So if you have, let's say, thickening of the nuchal plus ductus venous anomaly, and it's not, it could be a girl, and then you think of Turner syndrome, but exactly can be the picture of a Noonan syndrome. And later on, you may see cardiomyopathy, and occasionally may have other things. There are typical pulmonary stenosis, but I rarely see this antenatally at mid-gestation. So you see such a fetus here with a huge nuchal thickening and AV septal defect. First of all, you think of this AV canal, it's going to be down, but you look at this nice nose, nasal bone, it's not Down syndrome. And such a huge thickening, it's more lymphatic problem. And you see the ductus venosus here, and end up to be a PTPN1 mutation. So this is a kind of Noonan. So it can be associated with a typical cardiac anomaly, but it may not. And interestingly, if you ask geneticists, the ones specialized in Noonan, they will tell you we need to know what is the gene affected, because when knowing the gene, we can know exactly, even the mutation, the name of the mutation, they can know what's going to happen. So not only PTPN11, but also the details. They can say, in this, it's more likely to cause pulmonary stenosis. The SOS1 are more septal defect. This RAF1 mutation and RIT1 mutation, they have more hypertrophic cardiomyopathy. So it's not only Noonan syndrome. There are very good cases having, let's say, normal life, but there are cases where they may need another treatment after birth, especially when there is cardiomyopathy. So this is why it is one package. And ideally, if you perform 3D, you can see the low set of the ears, but you need to have a lot of experience in order to show the face and the ears. So this is why I look at the ears more and more often when I do the cardiac scan, because you will see later on, it is not only could be suspicious in 22.1, it is in Char syndrome, it is in Noonan syndrome. So in Kabuki, they have large ears. So it is should be part of your scanning, but I'm not looking this to every day, but in cardiac anomalies, I change my scanning when I see the heart. Now, the Char syndrome was for years an acronym for this abbreviation, coloboma, and so on. And 2004, 20 years ago, the mutation in the CHD7 gene was detected in 90% of the cases present. And then, in the meantime, we have a lot of experience because, let's say, children having some anomalies are diagnosed with this condition. It's 1 out of 10,000 births, so roughly as common as rhabdomyoma. So if you have seen rhabdomyomas, you can see the same number of rhabdomyomas cases are Char syndrome. But I can imagine that some would have been terminated because anophthalmia, microphthalmia, plus cardiac anomaly, you don't know the reason, or some may have died because there are some multiple anomalies. This is why I think the true number is underestimated. So you see here, we added to the face, the microphthalmia. So you have a kind of facial development problems affecting the eyes, the nose, and the ears, and this is more a facial structure. So when I see cardiac anomaly, I will just jump to look at the face and have 2-3 steps I look at the face because I think I could recognize this and that abnormality. So this paper is excellent, done by Nicole Carson-Jansen from the Netherlands. They did a multi-center study of children with Charles syndrome. And when I started learning Charles, I assumed it's almost always tetralogy of follow. But here you see there is zero role of your ultrasound skill, because you can have a septal defect, you can have AV septal defect, you can have conotruncal, you can have left obstruction, right obstruction, anything. So don't focus on the heart, because it will not help. Any cardiac anomaly can be associated, and even, you know, some 25% of the kids are not having even cardiac problem. But interestingly, when I spoke to her at the meeting, she told me, because as well, I have observed several cases with non-ARSA, said we have published another paper where aortic arc anomalies, including ARSA, are there. So 25% of the case of Charles, they have an aberrant supraeleven artery. So for me, when I see this condition, I will look at 22q11 signs and also Charles signs. So this is why you see it is more a facial plus heart, a brain abnormality, so posterior fossa may be a little bit dilated. You may have some, you think some vermis hypoplasia or megacisterna, so something unusual in the region of the cerebellum, plus some facial feature. This is the only case I saw with corneal atresia. It was confirmed to be a Charles. What I was observing, she was referred because of polyhydramnion. I saw in the region of the nose some debris and said, but if the baby is breathing, it should remove this away. And then I saw there was breathing only through the mouth, but nothing through the nose in comparison to normal fetus. I said, okay, as the geneticist, check please for us. And then what I did, I read somewhere that someone observed what is coloboma, and this fetus, I turned the probe to look at the eyes. So coloboma of the iris are not yet detectable, but of the retina, this is how it is diagnosed on MR. So in the posterior aspect of the eye, you see this gap, and this can also be seen antenatally. It was reported by Jean-Philippe Beau from France, and this is actually how we can look at it. You ask me, are you looking always at the eyes this way? No way. There is no way to do a screening and then to look at every fetus, the eye and the ear and the inner ear. But if you have a cardiac anomaly, you see for a moment, okay, look at the thymus look normal. So next one could be monogenic disease, could be Charles. Let's have a look to the eyes, let's have a look to the ears, let's have a look to the posterior fossa. Is there anything I can use? And this is here, Charles syndrome, coloboma. This was with cat-eye syndrome. Cat-eye syndrome or duplication 22. In general, they have anal atresia, they have ear tags, and this one was Cliffstra syndrome, they have thickened nucleus. So you see, in other words, if you know what you are looking at, you will be more careful in scanning this fetus. But I will show you at least here how a retinal coloboma look like. And the ears are the key diagnosis for the geneticists. This is what they want us to look at. So ideally, you have a view to both ears. They are very often asymmetrical, atypical. So the typical shape would be like this one. They have two different shapes, and this is what I will try to get when I'm looking to cardiac anomalies as well. I will not pretend that I'm easy in getting the semicircular canals. I know how to look at them, but I haven't seen yet any abnormal, so I cannot use them in my daily life work since I don't know how does the abnormality look like. But this one, for example, can be used after 22nd week gestation, and you can look at the guidelines of ISUOG because one of the pictures are there. And what we are doing now, we have a coronal view just in front of the genome of the corpus callosum. And you see here these two lines are the lines of the olfactory sulcus. It is developing, so we have the olfactory bulbs. They are embedded in the sulcus. And this develops because of the gyration after 27-week gestation. And one of the cases I got, this is normal, I got this here, this view. I went to the geneticist. I said, can you please do for me single gene, the CHE7? That why is that? Because I see there is RNA encephaly. I said, you are crazy. That you pretend now you are seeing the bulb nerves and I showed them the picture of the ear and said, okay, we'll agree, and it turned to be positive. Today, I think I will add it in my list, and they will do anyway in exome because they believe that exome is worth to be done instead of seeking a panel, one gene and another gene, because you will not finish. I will call it not a new syndrome, but was a syndrome unexisting in our list of prenatal diagnosis, which is Kabuki syndrome. It is quite 1 to 30,000 births, probably more common. That means it's not 20 to 30,000 is like achondroplasia and thanatophoric dysplasias, but I think it's more common. You will see in your work. There are two genes mainly. Sporadic genes in the KMT2 gene. It is 100% mental retardation, facial dysmorphism with maybe flat face. It may look like a Bender face. Typically for heart anomalies, it's typically the coarctation and hypoplastic left heart syndrome. So I can imagine that some children were born with hypoplastic left heart and died without operation, or had some complications later on, and they were due to the operation of hypoplastic left heart and missed all this issue here. So the term was called because of Kabuki makeup syndrome. The eyes are, you see the external aspect of the eye is, let's say, open, reminding this makeup of the Kabuki theater. And let's say prenatally, you may look at the eyes. I tried to show that there is a long palpebral fissure here, but it's more or less the small mouth and the small nose and the flat nose. But in general, it's more, let's say, the cardiac findings and additional things like single umbilical artery in 15% of the cases, abnormal ductus venosus in 20% of the cases, and you have some renal anomalies. So actually, it is a condition where you may think it could be factor syndrome. You have some vertebral anomalies plus. Look at now this Chinese study, quite interesting actually, left-sided lesions. Left-sided lesions, and we have 80 fetuses, 13 out of the 80s had monogenic disease, 7 out of the 13 had Kabuki. So, of course, if this study will be put in the meta-analysis of the CODE study published by Moen and Mark Kilby, you will find out that it is in 18 studies, 600 cases, 96 had exome results. So 15%, 15% of after having a normal karyotype and normal array, 15% had abnormal exome. Among the 96 cases, you will have Kabuki is the leading one. Of course, it may be biased by the higher number in the Chinese study if you have a meta-analysis, but at least it's nothing you should ignore. It is between the first 3 or 4 always. So Kabuki, Char syndrome, Noonan syndrome, and PCD. And if you look at the contribution, the yield is the same here. Now, Fiona published the other one, more published this paper with Mark, and they run first the QF-PCR and then microarray. You see at the end, the exome will be adding at least 10%. So roughly speaking, when you counsel the patient, you have to tell her, today we have 10% are going to be monogenic diseases after we remove all these things. So this is why the question is, should we wait until we run the exome, or why not to do it directly? Because 1 out of 10 is quite high. I was discussing yesterday with Simon and with Dario at dinner. We said, we used to do an amnio for a risk calculation of age and triple test of 1 to 280. Today we are discussing 1 to 10. This is why don't lose your time. So this one should be added in your list. I used to say in the past, if you have status anomalies, I will put it in my talk on heterotaxy. Status anomaly, there is no reason to do, let's say, amniocentesis because there is no genetic disease. No, there is no aneuploidies. You rarely have Down or trisomies, but you have PCD quite often, and this may play a role for postnatal follow-up because they may have lung development like in cystic fibrosis, and there is today treatment for this. So this is here, you see, this is an autosomal recessive in consanguinity patient, or don't forget, if you see cardiomyopathy, there are genes for cardiomyopathy known. So either you run the panel of cardiomyopathy or you do the exome because they are always included. And this is here, the ME7 gene mutation. Now, you have to keep in mind when we are doing genetics of cardiac anomalies, if we are looking to clinical exome or if we are looking to panel, we are selecting cases of known syndrome, and we'll find only syndromic. Syndromic means allogene charge and so on. But we are not finding any other abnormality on the genes. This is why if you run exome, for instance, especially if you are doing trio exome, so we are seeking the 5,000 possible genes, you may find syndromic but also non-syndromic. What does it mean non-syndromic? Because if you read the paper, you don't understand what they want from me. Non-syndromic means following. If you look at a paper on how a heart is made, and this is the genius development. So I don't know. I think God should be a geneticist, actually. So you have here genes like TBX1 or the notch gene. So there are genes related into cardiac development, and a mutation of a gene may lead to a cardiac anomaly without having, let's say, a syndrome. You may only explain why this heart anomaly occurred. And the only example I could show, but unfortunately I don't have the data for, is this patient from Ethiopia. She came to see me because she had a VSC, spontaneous close. 2016 came to see me, and then every second year came back. Every year, a muscular VSC, muscular VSC, muscular VSC, muscular. So that means if I had a chance to examine her, I'm sure we'll find a gene. This gene is explaining all are healthy. The mother is healthy, and the children are healthy. They have even good reproductive. These children will come back to my successor, and then they will have other VSCs. But this is what we call non-syndromic. That means, in good terms, the 10% results are not sick babies. They are babies where you have an explanation. But then in the database, you can see that some cases may have a different, let's say, clinical follow-up, and they may have different, they may be having some diseases later on, but at least it may explain. This is the role of non-syndromic CHG. So your question, ideally, we do it the first semester, because in the first semester I have next day karyotype, the day after the 22.1. But if you do the second trimester, your question, Simon, will be asked this way. In cardiac anomalies, we do in Berlin karyotype with CVS. We do first the 22.1, occasionally selective FISH, but we just run with the exome. The main problem is if you do it the same at 22 weeks, you will need, if you run this way, microarray, and you wait 2 weeks, 3 weeks for microarray, then you start doing the exome. It could take longer. And if you look at the data today, what I present to you, let's say after 21, you have 3% microarray versus 10 to 20% exome. It's worth to do the exome parallel to the karyotype. And our geneticists, they do within the exome also the result of the microarray. So what to tell the patient tomorrow? This is a number I'm using, it's in the book. 100 cases of cardiac anomalies, 15 will be chromosomal anomalies, the remaining 6 will be microarray divided into half, 22.1, the other half, other deletion duplication. Remain 8% of the cases, depending on what the test and on the association of isolation of cardiac anomaly, you'll have 10% single gene disorders, or if you have additional signs, you may again end up of having 30% being abnormal. So this is actually the good numbers, because this is how I counsel patients. I tell them, under the bottom line, it doesn't look like down 18, 13, because we know this. We check 22.1, but we check the 10% of isolation. Now, geneticists ask me sometimes, but if it's isolated, why do you do more? That, there is no one in the room who can say it's isolated. Who will be able to say at 20 weeks there is an absence of the olfactory bulbous? At the end, after birth, it's not isolated, but antenatally, rarely you can really promise it's going to be isolated. Growth retardation may appear 30 weeks. Dilation, ventriculomegaly may appear 30 weeks. So later on you say, oh, now it's not isolated anymore. Let's do exome. You are 35 weeks, so good to know a day before birth. And people say, your patient said, but you said at 18 weeks there is cardiac problem. Why now at 36 weeks you are telling me there is more? Thank you very much for your attention.
Thanks, Rabbi, for a fantastic talk, and it's ignited so many questions in terms of how we do things, because we all do things differently in terms of genetic screening, and there are so many implications with regard to cardiac diagnosis and timing of exome sequencing. And when it comes to Q&A, I honestly want you to start putting your questions together, because it's probably one of the evolving areas in where we are with prenatal diagnosis, and the water is a little bit murky.